say you start measuring is, do I use this one, do I use that one? If you think, well, this one looks like it'll fit, but this one looks like it'll fit too, it's better in an oropharyngeal airway to go bigger than smaller. Because if you think about the concept, if you push the tongue back, you're creating an obstruction, versus if you reach back and you're pulling the tongue forward. But irregardless of whatever it is, just think of the concept, what do I need to do to move the tongue as far anterior as possible, and that's what you want to do. So whether it's a nasopharyngeal that you're putting in, I use nasopharyngeals a lot when I'm doing nasal intubations. Simply because I can try the right air out, because that's where it goes. I put it goes in without problems, and the hurricane spray that we use to numb the back of the throat has got a straw on it like WD-40. Well, it's a rigid straw like a coffee stirrer. Well, it's hard to spray that in the nose and get it to the back of the throat unless you've got a nasopharyngeal in. You can hold that straw and insert that dude, and when you squirt, it'll actually hit the back of the tongue and the areas of the oral pharynx, which works. That's optimal use of it. So there we go. So as we start measuring, I got some hand sanitizer here because we mess with this stuff here. It gets a little sticky, so I got some hand sanitizer for us to clean up with. So if you don't mind, just measure an oropharyngeal airway, stick it in. Now what they're talking about, you can insert them upside down, and that simply requires you to put your finger in their mouth. So if they're lifeless, they're not going to bite you, but if they're agonal breathing, I'm real resistant to put my fingers in their mouth because they're kind of like an alligator. You put your finger in their mouth, they're going to bite down. So you can put it in upside down till you feel the soft palate, rotate it. Now I always rotate mine counterclockwise because the idea is I want to move the tongue to the left side of the mouth because this is a left-handed tool. But if you notice, when you put these things together, you're looking down the right side. So if you have the tongue displaced all the way over to the left, you're creating a larger view window. In an adult, it's not that big of a deal. But when you start dealing with children and small infants, it creates your field of views getting much smaller. So this is not an intubating class, so I'm not going to... If you want to look and see if you can see it, that's cool. This is an easy mannequin to intubate. They talked about using a tongue depressor. You can actually, a lot of docs will carry tongue depressors. You can reach in, grab the tongue, move it forward. I have seen people, anesthesia people, because they've got them laying out, they'll reach in the laryngoscope, pull the tongue forward, stick an oral airway in behind them. There's lots of ways that you can do. The thing to remember is if you're ever in a scenario where someone's going to intubate and they have the laryngoscope in their right hand, they say they're ready, you need to choose someone else to intubate. Right. This is a left-handed tool. It's been proven. How many times have you been working in the emergency department, EMS, or somebody turns a patient to you and they say, I saw the cords are intubated, and you hear air leaking, or it's out. What will happen is I go in and I look and I see the vocal cords. I put my cuff in, see it go past, or an infant go past the glottic markers. I know I'm in place. When I withdraw, because this tube's got an end on it, it'll pull it back a little bit. Adults or patients are using cuff tubes. What will happen is that cuff will place itself between the vocal cords. So you've got half of it blown up on the outside, half of it blown up on the inside of the trachea. You're still getting gas exchange, but when you move them, or you start doing some stuff in the ER, or just CPR will migrate that thing out, now it's out of place. So what we start doing is we use a glide scope. We video our intubations, and we video it all the way to the blades out of the mouth, so you see that the cuff is left distal to the vocal cords. It's in correct place, or the glottic markers beyond the vocal cords. You're there. Then you can rely on your capnography. You can rely on your assessment. Remember, if one of you draw the scenario today where you have the intubated child and anything happens while you got them on a ventilator, immediately put them on a bag valve. That eliminates equipment, because remember, dope, displacement, obstruction, pneumothorax equipment. That eliminates the equipment because you can feel what you can't hear from a vent if you're not used to listening to one run. The next thing you want to do is you want to definitely listen to breath sounds. Now, in an adult, you can listen to breath sounds up over the nipples, you can listen to them beside you. In children, small infants, you're going to have to go way deep in the bases to get away from what you hear in the larger airway. So if you start having some trouble bagging, you start noticing some abnormal movements of the chest, listen deep and start looking for tension pneumothorax, especially in asthmatics. Because what happens in asthma, and we'll talk about that a little bit lower in the lower airway, Remember, you can get air in, but it can't come out. So when you overinflate, that's when you're going to cause a pneumothorax, which is going to progress to a tension pneumothorax. Now, I said earlier that it's harder to see tracheal deviation in children and infants than it is in adults. The only adults I've ever seen tracheal deviation is trauma arrest or morgue patients. You don't typically see a tension pneumothorax when you see the deviation. That's a very late clinical